1.
Good morning, good afternoon. Hello, colleagues. It's really great to have you all with us again in this one of the interesting sessions of this Health System Research Symposium 2020. My name is Awad Mataria, and I'm the Director of the Department of Universal Health Coverage and Health Systems, working for WHO Regional Office for the Eastern Mediterranean based in Cairo. It is my pleasure to be with you today, along with my colleagues who will be sharing different experiences from different parts of the world. One of our colleagues will be joining as well. He has some glitches with connecting with us at present, but he will be also joining with us, and he will be continue the moderation and the chairing of the session. Our session today will focus on one of the key questions related to the overall agenda of universal health coverage, a topic that has been somehow left behind in many initiatives working towards promoting universal health coverage through different platforms, through different health system strengthening initiatives. And this is the question of how to design and how to define a benefit package under the overall umbrella of universal health coverage. And our prime focus will be on how to leverage different criteria into the definition of a package. And in particular, we'll be focusing on issues related to economic realities, economic imperatives in countries, but also social preferences and people views. I'll start the session with a short introductory presentation, and then we'll be listening to different interventions, presentations from colleagues who are on the panel as well. So if I would like to share my screen now, and I will be doing that right away. You tell me if you can see my slide. Okay. Can any of the colleagues confirm that they can see my slide?
No, not as yet. We can see you, but not the slides yet.
Thank you, Sami. Can you see my slide now?
Yeah, we can see that. We can see that.
Wonderful. So thank you very much. So as I mentioned, my introductory presentation is about how to look at the question of defining benefit packages, or what economists also like to do, to call the benefit design, as an important way forward for building future health systems, ones that would allow us to move towards the goal of universal health coverage, but also we can discuss nowadays with the pandemic other imperatives and other goals and objectives for the health system. I would like to start by reminding ourselves by the big elephant in the room. I mean, nowadays, when we prepared for this session, COVID was not here, and we were discussing different issues related to the technicalities behind defining a benefit package for universal health coverage. However, with COVID being around, one cannot look at this question without looking at the overall impact that COVID has made on health systems in general, but also on this question of benefit design. So I would like to start by reminding ourselves by some observations that we have been compiling on the impact of COVID on health systems at large and different health system components. So COVID has demonstrated more than ever the importance of having good governance in countries, the importance of collaboration, the importance of leadership, the importance of partnership. And this relates itself very closely with the overall question of defining what benefits, what entitlements one would need to deliver to everyone in a country under the agenda of universal health coverage. COVID has also highlighted the challenges in different countries globally, but if we talk about our region, the region where I serve, which is the Eastern Mediterranean region, the issue of the weak and rigid public financial management systems that are not allowing to release and to make available flexible financial resources in order to allow for delivering and providing needed health services to the population. So this is again a question that we need to have in mind. How to adapt benefit packages under conditions of austerity, under conditions of emergency. But also COVID has highlighted that the models of service delivery, models of care in countries are not fit for purpose. Primary healthcare has not been prepared to be able to deliver on the public health functions, whether things like issues related to triage, to contact tracing, but also the overwhelming demand on hospitals resulted in overcrowded hospital care, which has also been something to look into in defining how we want to deliver a benefit package under the agenda of universal health coverage. Also, what happened is that some malpractices became prominent, especially in relation to the use of medicines and medical products. We have observed that in many countries there has been some irrational selection, challenges in the distribution and the supply chain of some medical products and some medicines. And last but not least, the pandemic has highlighted the importance and the pressure that that an emergency of this tool is putting on health workers, on health workforce. It highlighted their shortages, also some of the shortages in some certain specialties, like in infectious diseases, in other specific areas. So going back to that specific question of benefit design and benefit packages, the way that we have been conceptualizing it at least in the regional office here, working with our member states, is how to come up with a set of interventions that we would like to call them as priority interventions. We label them as priority benefit package under the label of universal health coverage, and to have that as being the starting point for designing the overall health system to ensure its delivery. So we are putting this at the center of all different health system components, what we also refer to as the building blocks, being governance, information, service delivery, financing, medicine and technologies, and human resources. So if we know what we want to deliver, we can shape up the health system to ensure its effective delivery. And the other thing that we would like also to emphasize under defining these sets of interventions, that those interventions are not only about curative care, and they are not only even about individual or personal care. So we'd like to look at them as being an amalgamation of individual services and population-based services. Under the individual services, here we talk about promotive, preventive, curative, rehabilitative, and palliative care. Under the population-based interventions, we refer to issues related also to prevention and promotion, but also what we refer to as well as intersectoral actions or fiscal policies. So these are strategies or policies that we would like to see as part and parcel of an overall set of entitlements that we want to deliver to the countries. Now, if we come to the details of what to include in such a benefit package, so it is obvious, and many of you might have worked on this, there are many criteria to be considered in defining a benefit package. A good way of presenting those is to group them into technical criteria, things that are related to the burden of the disease, things that are related to the cost effectiveness of different interventions, but also to issues of, things coming from epidemiology, coming from public health, from medicine. But also there are a group of criteria that are more of political connotation, whereby you would find in some countries that because of certain political interests, because a country is defining its benefit package at the time of an election, then there's interest to include more and more in that benefit package. But also there are issues related to political pressure, people pressure on certain interventions to be included in a benefit package. And last but not least, there is also the pressure from the providers and their own interests and their own concerns about what should be included in the benefit package. And the third group of sort of criteria that are being considered are more of, we qualify them as ethical related or issues related to the right to health, to the equity consideration in the definition of the package. So I want to look at what are the needs of population, vulnerable populations. Yesterday, we concluded a 10-day course on the health and well-being of refugees and migrants, which is a big question for our countries in the region here. So how to cater for their needs in defining a set of interventions within a benefit package. What I would like to say here is that there are many criteria to be considered, and what would be important is to have a dialogue around those. So what to consider at a national level in defining a benefit package towards a universal health coverage. So here comes the question of the economy in the country, of the social preferences, and hence the main theme of our panel. Now, going to the question, taking this question practically, there have been different approaches, different pieces of work that try to set or identify sort of elements or steps to define a health benefit package. They are not, created in stone, so you would find different approaches for doing that. But in a nutshell, one would need to start by defining what is the goal of that benefit package. What do you want to reach out of this, defining this benefit package and ensuring its delivery. Then to go into a process of operationalizing the different criteria that the ones that I have just referred to, and to undertake different pieces of analysis at country level. So there is lot that is done at the global level, but what counts is what is done at country level. And that's why it's really great that we'll be listening to experiences from countries from the region about how they went about, and we have some of the great experts who have done such analysis themselves and will be sharing with us their experiences. Once this analysis is done and data and results are obtained, then there should be deliberation, debating the different results from these analyses in order to make recommendations and decisions, which are oftentimes political in nature, because once you decide on including something, then you would, by default, excluding something else, which might benefit some people and deprive others. But what is nice about this, this approach that I have selected to share with you, is that it is a cyclic approach. So it's a continuous process. It's not like defining the benefit package and then that's it forever. It is something that should continue and we should keep revising it. Hence, the importance of building the institutional capacity at a country level to be able to do this exercise on continuous basis. I started with reference to COVID, and I would like to conclude with referring to COVID again. And it's great that one of our colleagues on the panel, Terry Reynolds, has been a key author of this document that I'm showing you, which looked at how to maintain essential health services during the current pandemic. And this is a question that was somehow not taken seriously at the beginning of the pandemic, with the expectation that this is a virus that would vanish in a few months, or when last summer was expected when it would come, the virus would disappear by itself. But then with the long existence of the pandemic, then we started to look at how to ensure that other essential health services are maintained. And this is really a report that I would really recommend to everyone. But at the heart of it, there are 9 actions that have been identified to be of priority to maintain essential health services. And I highlighted in red here the things that are related to our topic today. So how to define a context-relevant essential health services, and how to optimize also the service delivery platforms to ensure their delivery, and how to adapt and to change the patient flow in relation to that demanding these health services to guarantee that everyone who needs that healthcare has access to it. My last slide is to refer to a recent product that WHO has worked on, which is called the Uhc Compendium, which should try to bring in the different interventions and the evidence around them in terms of their cost effectiveness, and to enlist them in one platform that is made available for countries to select it from, to take them, adopt them, adapt them to their context, to define their own benefit packages. And I'm highlighting here very briefly some of the criteria that have been taken in defining what is included in this compendium, issues related to the burden of the disease, but also cost effectiveness, but also that there has been some reference to the equity implication of these interventions and to their consequences in terms of financial protection. I would like to stop here, and I would like to hand it to our chair of the session. Let me check if my colleague, Dr. Riza Majdadeh, who was supposed to be with us, managed to...
Raza has joined. So maybe, Raza, you want to moderate the section?
Thank you so much. Good morning, colleagues, and good morning. I want to actually ask Dr. Samin to actually chair the session.
Okay,
please.
Thank you, Riza.
Okay, thanks.
Thanks
very much. So thank you very much. What we're going to do is that we're going to go straight to the next speaker, and then towards that, at the end, we'll have time enough for discussion. So I'm really now going to turn to Terry Reynolds. Terry Reynolds is the unit head, Clinical Services and Systems, Integrated Health Services Department or unit or department in headquarters in Geneva. And she will be talking about, of course, she's already referred to her document, but she'll be talking about essentials package from I think a clinical perspective as well. But I'll leave it to her. So Terry, over to you. You have 10 minutes.
Thank you very much, Samin, and thanks very much, Awad, for, it's always a challenge to speak after you, but that was a perfect framing for what I'm going to cover today. So there are a number of criteria, as Awad mentioned, and you see I'm picking up on this slide from him, that countries will choose to use and inform their development of service packages. However, one of the things that we've seen is that in the COVID context, we're understanding more and more the need for integrated primary care in order to serve these functions that you see here on the right, especially those around continuity and coordination. And similarly, we're seeing the need for explicit attention to integrated emergency care, which is the other side of the coin for first level access. So for access at the primary level of the health system. And this is just to pick up on the special context that we're in. We were all working on these things prior, but now these are becoming more and more clear. And the reason I mention this is because my particular topic and job on the panel today is to look at, among all the other criteria that countries will choose to consider based on their own needs and context and values and desires, one of the things that has always been a challenge is that packages often work from sources and lists of services that are strictly on the scholarly cost effectiveness literature. Now, that's not always the case, but that has been a big part of the process for many countries. And what happens when you do that is that the way that we study the cost effectiveness of an individual intervention is quite different than the way that we need to plan health services. And so what we've seen over the years is a bit of a disjunction, the sort of creation of a package that has a lot of good information about effectiveness and cost effectiveness, but that leaves a big gap between that doc, it's just kind of no man's land between these very well-developed, in many cases, packages that have been based on a very robust process of prioritization, but then face a great challenge in actually getting all the way to the level of service delivery. The other thing is that because of the way these lists and packages of services or benefits are often created, they sometimes end up actually not supporting very well, or at the worst, even undermining the values and principles that a particular country or community have for integrated service delivery. So it's very interesting. We get on the one hand these lists of services, and then on the other, these sets of priorities and goals for integrated service delivery. And it's very, very hard to bridge that gap. So we've undertaken over the last few years, working very closely with a number of countries, but really especially including Afghanistan and Ethiopia and Somalia, to really figure out how can we incorporate the values of integrated service delivery and the priorities that countries have for integrated service delivery into package development. And so what that means is that it affects the way that you formulate the services, but it also affects the way you structure those services, and then the way you interact with the list of possible services and interventions, and how you go through that process in order to select them. So I'm going to show you 3 or 4 mechanisms that we have discovered in terms of the package development process that ensures that the resulting package is more able to support and to facilitate rather than to inhibit integrated service delivery. So the goal when we do this, right, is to facilitate a structured decision making. So one of the other pitfalls that a lot of countries have faced is that they're starting from a certain package. Almost no one is starting from zero, right? Most people are doing what is technically a revision of a service package. And those are often packages with a center of gravity in maternal health or infectious disease. And so people go back to those and build on those. Now, one of the issues with that is that you can see what you might want to add or change, but it's very difficult to see a whole. So a hole is an empty space. Something that is missing is actually, it's easy to build on an existing package and never actually see the holes that are there in the first place. So in areas that are completely not covered. So it's easy to improve an area that is already included, but it's more difficult to look systematically at all the areas that are not in your package. So what we have done through a tool that Awad mentioned, and I'll show a little bit more on, the Uhc Compendium, is created a structured architecture to go through all of the possible relevant health areas and make sure that decisions about whether a service or a service area is included is explicit. There's no problem. Certain countries will say, look, we're not taking a service area right now. So there's no problem with very simple packages, but at least that decision is explicit. So nothing is left out accidentally. So the one is structuring so that you go through step by step with explicit criteria. The next thing is to have a systematic architecture across all health areas so that you can suppress an entire health area, but it's done with an intentional decision. And then the other is most of the list of services that people work from don't actually include the core primary care and emergency care, the frontline services that really respond to people's needs and that represent the core continuity and coordination functions of primary care. So the other thing that we aimed to remedy was to include services explicitly linked to these core continuity and coordination functions. Because if you look at the cost effectiveness literature, those are not very well represented. You end up with services for specific diseases for the most part. And the point is to make sure people don't show up with a given disease, they show up expressing their needs. And we really want to meet those needs and we want the packages to do that. Now, the reason this is so important is people develop packages, whatever they call them, service packages, packages of services, benefit packages, whatever they call them, they develop them for different reasons. But in the end, empirically, what we know is that these packages or list of services get used for all of these different use cases that you see here. And so it is incredibly important that we design them well to support all of these use cases. If you fail to do that, what you have is a package that has a lot of power to influence your service planning, your health workforce training, your supply chain planning. It has a lot of power to influence all those things, but hasn't been designed to do it effectively. So just to give you one example in Ethiopia, this is the example of kind of a joint document that does multiple things. As you see, there are a list of services, but then there's also an area in the blue where they're mapped to a given level of service delivery and another area that explains what the payment mechanism is. So this is just to show that this is a simple single document that has enormous influence on service planning, as you see in the blue, and then also in terms of payment mechanism. So the reason this matters, right, is you know, if you just put together a set of little incremental services that have been studied for cost effectiveness, and these are services out of a real package, they're at totally different levels of granularity, and also they don't add up to integrated service delivery. You get kind of a Frankenstein of you put together a lot of good things, but you haven't quite come out with a whole that represents your values and goals for the health system overall. And the reason that matters is your health system is trying to meet the needs of your people. You want these two things to come together. And so, you know, people don't show up naming their disease and telling you what service they need. What happens is they show needs that they are experiencing. And so our service packages have to also include services that cover the interval between when a person asks for help and the moment when we have some idea what their diagnosis is and what services they actually need. So that in itself is a very important process that represents a huge part of what primary level care has to offer. So that is the main business of primary care, is to translate from people's needs to the actual health services they need. So failing to represent those coordination and continuity functions explicitly is a big loss in our packages. And that's what creates packages that undermine the values of integrated service delivery. So one other thing I want to mention is that packages often end up in a situation because they don't incorporate attention to the level of the health system and the delivery platform. What happens is you get things that say, do X, Y, and Z at the primary level, then refer. But there's no one over here to catch that ball. So as countries develop packages and select services, we need a package design process that highlights the relationship across levels of the health system, across platforms, and that accommodates the priority and the importance of movement across the health system. So that is another kind of value of responsiveness that is needed in packages. So I'm just showing you very quickly, you don't have to look at this in detail, but the top, for example, is an example from Afghanistan's health service. And it shows how you might have certain simple services at the community level, but they need to be met at the other side by services at the higher level in order to actually provide ultimately what is needed to meet this person's health concern. And I'm just showing you two visuals of what it looks like to actually map services across levels of the health system. The second one I showed you comes, Awad had mentioned this, I'm just going to show you two more visuals and then stop, but the Uhc Compendium is up on the website. Right now it's in the database form so that the services can be seen. But what's coming next is the service selection interface. That is our response to trying to address all of the challenges that I've just described, and also to incorporate these values of integrated service delivery. So I won't go into this in detail, but we can, there's more information on the website, and I'm happy to answer any queries offline. But what you see here is the way that you might take a certain intervention and then distribute it across the levels of your health system so that it best fits your population's needs. Similarly, this interface allows the incorporation of economic considerations into the decision-making process. So this is the approach that we are currently taking at WHO as a tool to address these dilemmas and represent these values that I've just talked about. Thank you very much for your time, and happy to answer any questions later.
Thanks very much, Terry, and thank you for keeping to the time. And I'm sure there'll be questions later on based on your following your presentation. May I now turn to our next speaker, and that is Dr. Faisal Rifaq. Dr. Faisal Rifaq is the head of the Social Health Protection Initiative, and he's the head of the biggest social insurance program, which in Pakistan is called the Sehat Sahulat program, which is run by the government, by the federal government, the Ministry of Health. And I think it'll be a pleasure to listen to Faisal. So Faisal, over to you for you to share your experiences of how you're using a benefit package, and you have 10 minutes.
Dr. Samin Siddiqui, thank you very much. I appreciate that. And thank you everybody for the presentation. And Awad, it was really nice to seeing your presentation. Let me share my slide, which I have developed for this session. And here you go. So I'll have a very brief slides, and I'll go through them very quickly. And initially, I like to present what Sehat Sahulat program actually is doing in Pakistan, and how we are coping with the benefit packages, and how we have cope up with the indoor facility. And we learn from our mistakes and from our implementation experience, and just like to share that thing. So coming with that, just an outline that Pakistan, majority of the people who actually fell into the poverty in Pakistan is mostly because of the catastrophic health expenditure, with a 60% or more out-of-pocket expenditure. And most of these expenditure are being spent by the families or the patients on the admissions, the medicines, and the diagnosis facilities. We have seen many families who have had a once incidence of catastrophic expenditure, and they had to sell everything out. And in the end, regardless of the treatment outcome, the patient, the family are on the street because of poverty. Just to give a background of Pakistan, Pakistan has, as other countries, have both public and private healthcare facilities. Public healthcare facilities from the basic level to basic health unit to advanced tertiary care level in the urban cities. And the private healthcare facilities are mostly for the profit. The basic health units and the public sector facilities sometimes have cash problems and the funding issues. So they also charge or provide treatment when the patient has to pay for the usable items or other accessories. So still, that's why Pakistan has more than 60% out-of-pocket expenditure in healthcare services. So to prevent those families from falling into poverty because of catastrophic health expenditure, the CSO program, a social health protection initiative, came into being to improve the health status and provide access to the families, especially the poor, vulnerable, and marginalized families, for indoor healthcare services. We started with the program for only for the first phases for the indoor healthcare services, and then we are planning to expand it to the other areas. So the current benefit packages which we are provide are all is a family-based incentive, and for the poor margin is providing families with the indoor healthcare services only for which the admission is required. We are right now not providing the transplant services, but in the future we are going to focus on that. But other than transplants and implants, we are providing the hospitalization services, especially catastrophic. So the project the concept is to hire the private insurance company and provide them with the health insurance premiums, so that the families, the poor families who are data being extracted from the National Poverty Registry, can be provided with services, cashless services, either from the private or the public sector. If they want to go for a public sector, there is no hindrance. If they want to go to private sector, the insurance will provide the services. So, as I mentioned, all hospitals, we provide the indoor hospitals, we provide the cardiology, the cardiac treatment, the diabetic complications, the burns, accident, dialysis, chemotherapy, and radiotherapy. And right now, at this moment, almost 17 million families across Pakistan have been included in, covered under the social health protection initiatives, either federal or the provincial programs. There are few areas who have taken a big leap in providing the health insurance to all of their families, permanent resident families, and we are still in the process of implementation those programs. So in Pakistan, almost 27 billion public sector expenditure which are targeted towards the providing health insurance coverage to the families. Almost 450 private sector hospitals are impaneled in the program, so that if families either they want to go to a public sector hospital or they want to go a private facilities which are paneled with us, they can go and get their cashless healthcare services from there. We keep track of all the incident of the statistics of the program through our MIS, and we acknowledge, we see that the time the family is enrolled in the program, their utilization increases with the passage of time. We also keep an eye on the average claim costs which are we being paying for the program, and average length of stay which we are having in our hospitals. We were able to, because of quality and controls mechanism, we were able to down the hospital admission in 2000. Again, in 2020, because of the COVID and other thing, it went up. Uh, uh, Readmissions, the program is also following readmissions, and we try to maintain the quality at a certain level so that we can have a minimum possible readmissions in the program. So we are keep an eye. And this is the slide which is very important for us and which was a mind-blowing incident for us, that we were experiencing the gradual increase in the number of admissions in the program. But suddenly COVID's hit in, and what happened? Most of the private sector healthcare facilities stopped providing the services to the families. So ultimately, all of our admission trends, sorry about that, admission trends came drastically down, and we only reached to our about 30% of the admission which we used to do before the COVID situation. So this situation actually opened our mind that why we were focusing on the private, but suddenly COVID, disrupted those services, and the people were forced to go back to the public sector hospital. So what has to be done in the program? So along with that, the problem which we faced is by the people, that we were not only providing the primary healthcare packages, so it was not present in the program. They again had to be referred to the public sector hospital for the facilities. We were lacking public quality healthcare. Even in the private sector, we were lacking the quality healthcare service facilities in the rural areas. We have hospitals in the urban, but rural, we could not find those quality of standard hospital which we wanted to have that. Third point, we were actually, when we went into the field and we tried to panel the hospitals, there were some hospitals who had a previous experience of working with the insurance. They were good, but the new hospitals, we had to train them, to bring to their capacity to a level that when the insurance claim is to be, how to process the claims and how to submit the claims and how to expect to keep the record of the claims and then expect payments. So these were the key main issues which we started facing in our implementation period. And most of all, one more important thing, when we focused on the poverty, people living below poverty, we had a lot of trouble in providing the awareness. These were the people who don't go further with the internet, they don't go use the social media, they don't read the newspaper, or they don't see the television channel, or probably those television stations on which we air the messages. So awareness was one of the main key issue which we started facing, and we actually provide health cards to every family, and the bank started sending us the health card which was stuck in their ATM pins. People were trying to get the cash out from the ATMs, but it got captured by the ATM machines. So these were the few issues which we have started facing during the implementation. And with this number of families covered in the program, now we have started facing the fiscal space in the public sector expenditure, which is being provided by the program. Uh, it's was all the political pressures on the program that every facility has to be covered through public sector funding. But now we have started facing the fiscal space and the contribution by the provinces and the federal government in the program. The program has expanded drastically. It has provided the results, but expenses has increased drastically. So currently, with the ministry working in the essential packages of healthcare services, the program, the Sehat Solar program, which is providing indoor services, we are aligning our benefit packages with the packages of work with the WHO and the ministry on the essential packages of healthcare services. We are also trying to pilot in a couple of districts how to provide the primary healthcare services or outcome services to the program. And right now we are piloting in Islamabad with the help of WHO, in Gilgit with the help of KFW, and one or two districts in the Khyber Pakhtunkhwa with the help of KFW. So how we can incorporate the social health, the primary healthcare services in the social health protection initiative. Plus, we are also working with the WHO Alliance for Health and System Research to incorporate the research component of the program to have an operational research of how things are to be delivered and what problems are we facing and how we can systematically correct those issues. And also, we are also working, not working, actually trying to convince the public sector how to assure the financial contributions from the families. If the program is going for the people living above poverty line, then how we can secure a regular flow of contributions from the families who are above poverty line. So these are the few things on which we are working, and we are hoping that in coming days the packages can be enhanced as per the essential package of healthcare services in Pakistan, and somehow we can incorporate financial contributions. Below poverty is public responsibility, but the people who are above poverty, their financial contribution, the system has to be drawn to assure that thing. So with that, I close my presentation and looking forward to the question answer from the panelists in the end of the session. Thank you very much.
So thank you, Faisal, again. Thank you again for keeping to the time, and of course, bringing information, from the ground as to how the program in a big country is being implemented. So thank you very much for that. I just want to point out that what you presented was the package which is targeting the challenge of catastrophic expenditure, and it is focusing primarily on the inpatient care. But I'm sure you're going out to deliver outpatients, and perhaps later on you can talk about how do you want to actually start also providing outpatient coverage as part of your insurance program. With that said, thank you very much again, Faisal. I now turn to our next speaker, and our next speaker is Wajiha Raza. Wajiha is a consultant in the economic evaluation and analysis section in the health systems governance and financing department of in WHO Geneva and headquarters. She's a young and upcoming health economist, and we very much look forward to hearing from her. She was also actually involved heavily in the development of the essential package in Pakistan. So Wajiha, over to you.
Thanks so much, Dr. Smeen, and thank you to Dr. Faisal for that presentation. I think that gives it's really helpful to set up for my talk, because I think Dr. Faisal had some really good slides which showed real cost information and information on economic considerations. So maybe we can pick up from that, and I'll speak a little bit more about what are the different about incorporating economic considerations and defining a UHC priority benefit package. Now, before I get into what economic considerations we look at, just wanted to make a quick case for why we need economic considerations to begin with. And really, the bottom line is that budgets are limited in whichever setting you're looking at. And since given that budgets are limited, we need to define a benefit package that accounts for this limitation. And this may seem quite obvious, but often countries in different settings will undergo benefit package development exercises first and then cost them later. And what happens then is that you end up with really inflated costs, which end up making your package more aspirational and make it very difficult to implement. So when we talk about economic considerations, the things that we could or should be looking at is things like your budget impact from your intervention choice, from the cost effectiveness of each intervention, financial risk protection, which Dr. Smeen and Dr. Professor mentioned a little bit earlier, and concerns about equity. And I'll be going over some of these very briefly. So what do we mean by budget impact? Well, budget impact is an economic assessment of the financial consequence of your intervention. So briefly, like from a formula perspective, what that is it's the cost of each of your interventions and the population that will be receiving that intervention. So you multiply the two and you get the financial consequence of your intervention. Now that sounds quite straightforward, but of course, developing that cost and that population in need can be quite challenging. Since I'm speaking more about the economic considerations, I've added a little bit about how do you get to that cost. So there's a few approaches you can take. You can do a bottom-up normative ingredients-based costing where you're looking at protocols. And as the name suggests, you're looking at each of the ingredients in the protocols for that intervention. You can also do a time-driven activity-based costing where where researchers will follow health workers and look at how exactly they're providing that intervention, which is a bit more timely and can be a bit more costly. Then you have another approach, which is top-down costing, where you look at what is your total budget and what is the budget per intervention through a simple division. So these are just some approaches. Of course, there's a lot more data on each of them if you're interested. A second criteria that we use for economic considerations is cost effectiveness analysis that has come up before, I think, in Dai's presentation, also in Dr. Wad's. So what cost effectiveness is of course, it's the value for money that you get from your intervention. There are two main ways on how you can incorporate that in your benefit package development. So one is if you're looking at the medicines or the technologies within an intervention. So the example I've chosen here is for malaria. So you might say that you might have decided to provide care and diagnostic treatments for malaria, but you might want to decide what diagnostic, what process I'm going to use. So would be using a rapid test or a blood smear test or a microscopy. And to make that decision, you may want to look at the incremental cost and the incremental effect of choosing between those options. So that's one slightly more granular way of using cost effectiveness for budget package development. And then a broader way is to use it to compare between interventions. So an example is providing the HPV vaccine or providing treatment for depression. Very, very different interventions. And if you want to compare them, you may want to look at the cost and the effect of each of those separately in what could be an ACER or a generalized cost effectiveness analysis. And how to compare some of that information. And this is one method that health economists use is a health intervention bookshelf. And how this can help you is, so what this has done is it's put your interventions in order of their cost effectiveness. So A here is the most cost effective intervention and G is the least cost effectiveness. And this tries to incorporate both of the criteria I mentioned earlier, so your budget impact and cost effectiveness, and it gives you a package that is affordable and the most effective. So if in this example, if we're picking between interventions from A to E, that is actually the intervention choice that the benefit package that gives you the maximum impact in terms of maybe daddy's averted, if that's the health benefit that we're using. So other economic criteria that I know other people have also touched on briefly is concerns around equity. and financial risk protection. So on equity is how do we, I mean, there might be interventions that are not cost effective, but they may benefit vulnerable population groups. So how do we prioritize those groups? Within cost effectiveness, there are ways to incorporate this in your cost effectiveness formula. So there's an extended cost effectiveness, there's a distributional cost effectiveness analysis, which I won't go into, but that's one way to approach it, to actually put it in your cost effectiveness ratio. Other ways is to include an equity weightage, or just in your conversation, just explicitly say that these groups are priority, and so we want to include these interventions for these groups. Other considerations from an economic perspective is the financial risk protection. So you may want to prioritize certain interventions because they lead to catastrophic health expenditures or impoverishment. And that, I think that's what, and that the Sehat Sahulat program is a really great example of that, because they've clearly prioritized interventions for inpatient care that are leading to catastrophic health expenditures and impoverishment that Dr. Faisal was sharing earlier. So that's a bit academic and like the process, and I wanted to share some real world examples from my work in Pakistan, which Dr. Samin was leading, and can probably add more to if anyone has questions. So this is a real life bookshelf example for interventions on primary and community care. And what this shows you is, so what is your benefit package if you have a constrained budget of $9 per capita? What is the benefit package if you double that, and what is it if it's completely unconstrained? What are all the interventions that can be included? These interventions are coming from DCP, and this visual was developed using the HIP tool and was presented to the National Advisory Committee there. So this is just an example of that benefit of the bookshelf that I shared earlier, using some real cost data and using some real cost effectiveness information from Pakistan. And just to further build on an example of incorporating economic considerations is, so on the left here you can see an Excel sheet that was that we had worked on to get to the unit costs. What you see on the right is how this information was presented to the technical advisory groups, and on the bottom right, you can see that conversation taking place. So that what's happening in that picture on the bottom right is they're looking at both economic and social considerations to decide which interventions should get priority for Pakistan. And lastly, I just wanted to share some other tools that can be used for incorporating economic criteria. So one is the Uhc Compendium that Awad and Dari had shared earlier. This is so right now it's in like I mentioned, it's in a database, but upcoming we will have an interactive interface that will allow us to make those choices. And what the picture on the right is the HIP tool, which has been around for a while and also allows you to do financial planning and to do some costing work on benefit packages. So I think that's it for me. Thanks everyone, and yeah, look forward to your questions. Thank you.
So thanks very much, Vajia. I think that was a very clear presentation. Thank you for keeping to the time, but also I think there was a lot of clarity. So thank you very much. I'm sure there's going to be some more discussion later on. I will now turn to the final speaker of this session, and that is, of course, the organizer of the session as well, Dr. Raza Majtizadeh. Raza is a consultant on access to health services and UHC. In the Department of UHC and Health Systems in the WHO Regional Office in Cairo. Equally importantly, he has been the head of the National Health Research Institute in Tehran, in the Islamic Republic of Iran, and has been leading the health research agenda for many years in his country. Raza, I know you've been doing a lot of this sort of work in the region, and we would very much like to hear your experience in this area. Over to you.
Thank you so much. Thank you, Dr. Samin. I do not know whether you have my actual video or not.
We don't have your video, but we can see your slides.
Okay, and then the slides are in full mode?
They are pretty good.
Okay, let me start with this. First of all, let me seize the opportunity and give my highest esteem to all panel members that I had privilege of working with them in several countries of the region, including Pakistan, Somalia, Sudan, Jordan, and Iran. And I'm very keen that we have this panel today. My presentation today is complementary to the colleagues and open another dimension of the service package, which is the social values into the benefit package. Let me start with this point, that we can look at developing a package that says what services could be in and what should be out, and then the implementation, which is about what works. I repeatedly asking myself, how much is the chance of success when we are starting work on a package, and how long we must spend to see its complete implementation. I'm sure that many of us know several packages that have never been implemented, and also the implementation of package needs vast patience and several years are required. So the explicit evidence on the failures of the package is hardly available. I know several cases anecdotally from the region, but what I can give as examples from published literature are from Colombia, Peru, and Dominican Republic. In case of Colombia, the government commissioned a team of world-class experts to design a benefit package based on cost-effectiveness criteria. The stakeholders believed that the package violated the medical autonomy, and the new package was dropped. In Peru, a new benefit package was designed, where the previous package was more comprehensive, leading to a public reaction that the benefits had been reduced, and they did not accept it at all. In Dominican Republic, the entity in charge of updating the package faced with a strong opposition from different stakeholders, mainly due to lack of information about the criteria and process. But contrary, look at Thailand, about the success story of Thailand. During all these years that we are hearing from Thailand experience, they actually had 8 rival governments, 6 elections, 2 coups d'etats, 13 health ministers. And then, despite all fluctuations in GDP growth, which is in the right side hand of the slide, the budget of the health system raised constantly. It means UHC gradually owned by the people who had benefited from it, not by the political party who initiated it. So this is why the definition of Eastern Mediterranean Office developed for the package is a set of publicly financed, evidence-informed, prioritized individual and population-based interventions defined through a deliberative process which accounts for people's health needs, country economic realities, and societal preferences. The focus here is deliberation and social preferences through their values and choices, which are quite important. Because health systems are conceptualized and social systems embedded in social context and shaped by human agency. Values are key to health system change. Let me say, health systems software, including relations, norms, ideas, and preferences, is considered a foundational focus in health system. WHO Technical Working Group on Benefit Package proposed 8 principles. It is interesting to highlight 3 of them for this talk, which are number 2, be democratic and inclusive with public involvement, also from disadvantaged populations. Number 8, to be open and transparent in all steps of the process and decisions. And finally, number 2, which is to be based on national values and clearly defined criteria. Accordingly, the most common criteria that I have ever seen in the region as well as the other countries of the world is among these 9. And we have seen during the previous presentation as well. But really, societal preferences are considered in the practice setting. And this can cause undermining public trust, as mentioned in country examples, and resulted in dropping the package from implementation. And in many circumstances, we are actually ignoring the client's or citizen's voice during the design and implementation of the package. This is why that Eastern Mediterranean Office addressed this issue in 2 guides. The first is for developing benefit package, and then a recent work led by Professor Kapilash Rami, who developed a specific one for stakeholder involvement in defining a package. The steps are very clear right now, that who are eligible to represent the stakeholders in all stages of the data, working with the data, information, cost effectiveness, etc., dialogue and decision. The package needs stakeholder involvement from at all these levels of the work. For how, I should say, the modality, such as conducting survey, polling, or establishing committees are clear, depends on the degree of targeted involvement. And there are principles of trust, respect, inclusiveness, and transparency. And finally, this can have binding to the decision-making power, same as what we can see in the case of Thailand. So let me stop here, and with concluding that there are many benefit packages that never been implemented. There are a few cases of community involvement in the process of deliberation, which consider social values. Setting priorities is not only about the hardware criteria, I mean the cost effectiveness, budget impact, blah, blah, but also software considerations, I mean the public voice and social preferences are necessary. The successful cases consider social preferences and institutionalized citizens' involvement. And by this dimension, to be added to the other perspectives that we have discussed from the beginning till now, we can actually get a benefit package that the people can benefit them, and to get the UHC and to move forward to universal health coverage. I want to actually finish my talk with this slide to say, to be sustained, a health benefits package should be built on principles for good governance, including transparency, consistency, coherence, stability, and the point that I wanted to emphasize in this talk was stakeholder participation. Dr. Simon, thank you so much, and I'm handing over to you.
So thank you. I think that's a pretty good end to what we have had. We have had 5 very succinct and concise presentations. And I think we don't have any more, and I think we should now go to discussion. The problem only and the challenge for me is I don't have access to the chat box in this arrangement. So if anyone, if Raza, you have the access to the chat box, or if somebody wants to moderate, and then I'm happy to summarize towards the end, whatever I think would be the sum and substance of this session. So there may be questions from, because I know there are participants already. And I think the speakers would be happy to take that, but I don't have access to that, so I don't know who's asking questions.
I do so. I'm checking with the organizers. I do not have actual access to the QA.
So I can see there are more participants than just the speakers, so there are more numbers at least, so there must be some participants there.
Okay.
And the
Dr.
floor is
Swain, I
open.
can see the chat, but I don't think there are any questions
Okay.
so far.
Okay. So you have access to the chat box.
Yes.
Okay. Sure. So maybe I could then start with a few comments. Maybe I have the first for Dr. Awad Mataria. So Dr. Awad Mataria, thank you for giving us the overview. My question specifically would be, and given that you and WHO has been leading the work and responding to the COVID crisis, how do you see that in this situation? How does it affect the whole development of the benefit packages? And what do we need to factor in when we bring these challenges around COVID and other pandemics and emergencies as we move forward in the business of doing packages for our countries? I mean, maybe you want to throw some light on that, Dr. Matari. We can't hear you, Awad. I can't hear you at least. You are muted, Awad. You are muted. I'm unable to hear you actually. Can anybody else hear Awad?
No, I cannot.
Yeah.
No, Dr. Samin, I also cannot hear Awad.
Maybe if Awad, you're getting ready for this, can I deflect the same question to Terry? Terry, your experience, because you've done this whole document, and how do you see it from the perspective that in the event of these pandemics and the crises, how do essential services come in? Maybe you want to say something on that, please.
Sure, thanks very much. I mean, I think there's one really interesting factor that it sort of comes up implicitly that people have not been totally explicit about. And that is the fact that there are certain core competencies of UHC and making progress towards UHC that we have been building and that countries have been working on for the last couple of decades that actually are exactly what makes you able to respond dynamically and in an agile way and quickly to a crisis like COVID. So one strong example of that is the most relevant here is UHC itself. The core capacity of UHC definitionally is the ability to prioritize a limited subset of services from among all possible services that you want to guarantee to all of your population. And so the ability to do that in a systematic, equitable, transparent way, et cetera, so that it best to maximize benefit to your population, but to also incorporate a number of values and principles. The ability to do that is the same capacity that has now been called on in COVID to select an even smaller subset of services that need to be maintained and prioritized and shifted during the pandemic. Now, what I think is really important to recognize is, and also just very interesting, is that the criteria that a country would use to identify that smaller subset of essential health services is really different than the ones that you would use initially to select services for a UHC package. However, the process is the same. And so an interesting example of that, not only is it different, the way that you would select a smaller subset for essential health services, but it's also dynamically changing throughout the pandemic. So for example, in the very early days of the pandemic, you were highly prioritizing things that would do you harm in the near term on the order of hours, days, or months. And you actually you had no problem suspending services that were only providing a very distant benefit. So some of our most important, most cost-effective preventive health services it was very reasonable to suspend those for a period of weeks or even a few months. Now in the late pandemic phase, we need totally different criteria. So we still want to prioritize life-saving services. However, with a pandemic that's extended this long, you're also changing your criteria to something a bit closer to UHC prioritization. So anyway, I think that is one of the strongest links. And it's why I think the countries who had invested a lot in UHC were actually relatively well positioned to respond effectively. So over.
Yeah, thanks very much. I do not see Dr. Mataria or Awad. So I will turn now to Faisal. Faisal, I think you talked about the delivery of the package, and you're targeting the poorest population or obviously below poverty line in the country. And I think that one of the things that you want to do is to reduce the level of catastrophic expenditure, in an already poor population, and provide them financial protection. Is there, and I'm very happy to see that you're also, you have a kind of a health systems research or an implementation research program going on with WHO and the Alliance. So do you have, or have you already looked at the impact of your work in terms of protecting these populations even further from becoming even poorer, because you already start with poor populations? And is there any plans to take this work forward?
Dr. Samin,
yes, go ahead, Faisal.
Yes, thank you very much, Dr. Samin. Yes, when during the implementation, we actually done with the support of Dr. Awad, we have done actually the baseline survey of the program, and then we did in the end of the second year, we did the implementation, a process evaluation, that how the program has been implemented. So that process evaluation results came out to be effective as the program was planned. Right now, we are in the process of conducting the third-party validation or an impact evaluation with the program to see how it makes any did it made any impact or not. So I'm sure that we will be able to have the results by the end of or the end of this current calendar years. So then we can share with that on the with the larger audience. And your second question was about, can you repeat your second question?
No, this was my main question, is how do you measure the impact of yours? And I think you responded to it quite well. Given that we don't have a lot of time, maybe I'll turn to the other colleagues as well. And so Wajiha, I think your point about from being aspirational to be implementable, as far as I think it's an important one. I think it's a key point in this whole discourse. And we have been talking, and we've been hearing about countries like Ethiopia, Somalia, Afghanistan, of course Pakistan, and these are real underspenders in health. So in these kinds of very, very challenging situations, how do you address the fiscal space challenge, which really becomes the major limiting factor? And what is the kind of, what countries need to do when they're defining their package so that they get the best bang, in a sense, for the resources or the money that they have? Over to you, Wajiha, for this quick response.
Thanks, Rasmin. That's a really big question for a quick response, but I mean, I'll do what I can. And so I agree that that's moving from aspirational to implementable is a key point, because it actually happens quite frequently that we develop benefit packages, and then when you cost it, it's too expensive. And I think so using cost effectiveness information to make those selections and to explicitly prioritize at the start what you can and what you cannot afford is really important. And what I didn't really go into my presentation, but would be really good to supplement this work is some health financing assessments that go alongside it, so you can see how much fiscal space you have, what is your projected growth in the next couple of years, what is your cost per capita, what do you expect it to be, and how do we use our current financing arrangements to fund this package effectively? What are the different health insurance mechanisms that your country may have? How are you financing this? Because of course that has a key role to play in prioritizing this benefit package. So in a nutshell, you should use cost effectiveness and costing wherever possible, and also do a health financing assessment alongside.
No, thanks very much. And so an important message for countries like what I've just mentioned or alluded to is that, yes, while you're developing your benefit package, you need to do a fiscal space analysis to see from where you're going to get the money, because having a package is very important, but then to be able to find the resources to be able to implement the package is as important as having that. Otherwise, it would be a self-defeating exercise in some ways. So I will now turn for the final comment from to Reza. And Reza, I think you really highlighted the point about whether you call it community engagement, stakeholder participation, giving voice to the people. And I think you took the example of Thailand, which I think is one of the shining stars in this regard, where there is a lot of engagement in terms of the People's Health Assembly and so on and so forth. And Iran also has done something similar. Do you want to share whether in Iran you also are doing something similar in bringing communities engagement as you move forward in your UHC agenda? Raza, this is for you. You're muted.
Yeah. Thank you. Very good question. There are a few actual platforms which are very suitable for this kind of work, and we have this discussion on how we can use those platforms for the purpose of community and stakeholders involvement. I can give you the example in Tunisia, in Lebanon, and in Iran. And in particular example of Iran, we have national assemblies that it has a very structured level of the community participation, from the neighborhood to the district level, and then to the provincial level. And at the end of the day, we have the National Health Assembly, which actually had this sort of community involvement. The point is that still there is no linkage between package to these structures. I mean, we have some sort of structures in the region. I have mentioned the case of Tunisia and Lebanon and Iran, but still there is no relations between purpose setting that can actually come with the decision of selecting services and actually looking for the societal preferences from this perspective. Therefore, we have some sort of background works, but still they are not linked to each other. And the one problem was the COVID, because it actually postponed many of the activities regarding community participation in this regard. But in Iran, as you have mentioned, we have very strong structure for the improvement of the UHC. In particular, we can use it for the revision of the benefits package in Iran. Yeah.
Thank you very much. I think let me try and summarize, because we are only left with just about a couple of minutes. And I thought that was a very interesting and a very good engaging session for all of us. As a matter of fact, I would like to come up with 5 or 6 key points, based some of them, of course, on my own experience of working in the area of benefit package. First is, countries in the past have not been very keen, because when you are doing a benefit package, please remember every country has some form of an implicit package, but when you are doing a benefit package, you are making it an explicit package. Now, explicit package means this comes in and this goes out. And sometimes countries don't want to say that. Countries are a bit reluctant. So it takes a bit of advocacy and convincing for countries to move in that direction. And I think the countries are moving in that direction, but it's important that we do have, because as countries move towards insurance programs, they have to be quite clear about what they are offering, what is reimbursable and what is not. So that's important about when you're doing it. We also heard a lot about the various criteria, and we talked about the burden of disease and cost effectiveness and equity. I think I'll just, and the budgetary impact, I think I'll pick up on 2 points, which I think are important, at least in the context, among all the others. One, I think, which needs to come up is the feasibility. Now, feasibility doesn't get captured into a software or into where you put in, it sometimes comes based on some judgment call. And that's what we learned in the case of Pakistan when we were doing the benefit package, that, you need to see whether you can actually do it in the system, or there's a system ready to be able to implement that or not. And the other, which is, of course, COVID related, is the urgency. And I think that also can become an important factor. And I think COVID has shown that to us, that you need to sometimes, it's not just about all these other criteria, but urgency could also become an important criteria. Now, once you are moving in the direction, so there's a clear development of the package, but then the big challenge countries will have, and I think many countries like Afghanistan and Pakistan and Somalia and Ethiopia and other countries in sub-Saharan Africa, is when it gets to the level of implementation. And I think it requires a fair amount of investment in the health sector to reconfigure. And a very simple and a clear example in most of these countries is, I mean, the primary care systems of these countries are not configured to deliver chronic care or NCD care. And so you need to really reconfigure. If your package has all those NCD interventions, then you need to sometimes reconfigure your primary healthcare system to be able to strengthen in terms of being able to provide the kinds of services that chronic care needs. So that's not easy. Training your workforce, revisiting your essential drug lists, strengthening your laboratory capacities, and so on and so forth. And that's a fair amount of investment, in addition to, of course, the cost of the intervention itself. My other point is also about engaging the private sector. And I think even if you define a package, I think in these countries, without engaging and partnering with the private sector, I think it'll be very, very difficult. I can tell you in India, in Pakistan, in South Asia, certainly, the first point of contact is not the public. So is the case in Egypt, and I think even in Iran and Morocco. And so we need to be cognizant that without engaging the private sector, and I think we don't have the time to get into that, but that's another whole discussion. But that point, I think, is extremely important, you know. And then, of course, your monitoring and evaluation mechanisms. Of course, you have the Global Service Delivery Index and the indicators that the World Bank and WHO have developed to monitor progress to UHC. But I think we need a strict monitoring and a rigorous monitoring system within our countries to be able to do so. And last, I think we have not touched enough, and I would like to close by recognizing the work that has been done by the Disease Control Priorities Initiative over the last 5, 6, 7 years, led by Professor Dean Jameson, you know, in coming up with these volumes, which is all available on the web for countries like us to look into, that offers a wealth of information for low and middle income countries of what are the most cost-effective intervention. It is not something which is tailored, but it provides good insight into what and how countries could benefit from that. And I think Pakistan so far has made good use of that in developing its package. I can say that many countries can also do the same, and I think they have moved in that direction. So with that said, and we are approaching very much the closing of the session, I would like to thank all the speakers. I would like to thank Dr. Madaria, Terry Reynolds, Faisal, Wajiha, and Raza for organizing this session. I would like to thank our hosts, and I wish you best, and I wish you a very, very nice day. So thank you very much. With that, I think we will close the session and say goodbye to all of you. Bye-bye.
Thank you, everyone.
Bye.
Thank you, everyone. Thank you, Dr.